Thank you very much for the nice introduction. It's a pleasure to see everyone here, and welcome to Understanding Substance Use Disorders as Chronic Medical Conditions. Anyone attending the conference is, of course, welcome to be here. We formatted this particularly so that it will meet some of the training and education requirements of the district initiative, the regional district initiative. And how many of you are engaged in the districts at this point? Okay, so a number of people, but probably not a majority. So the training and education credits that this will be fulfilling are Introduction to Substance Use Disorders, the medications in addiction treatment, or MAT, pharmacologic therapies, and a segment on alcohol, tobacco, and cannabis use. We're dividing it up so that I'll be starting and doing the intro on substance use disorders and talking a bit about the pharmacotherapy of opioid use disorder, and Dr. Brunette will be focusing on alcohol, tobacco, and cannabis use disorders approach to evaluation and treatment, and information related to that. My name is Seddon Savage, and I have been working in the fields of pain medicine and addiction medicine for, well, several decades now, and probably have crossed paths with many of you in the context of that work. I'm currently working as an advisor on education to the Dartmouth-Hitchcock system as it works to transform care of people with behavioral health disorders. I also am honored to serve on the Governor's Commission on Alcohol and Other Drugs and work with the Opioid Task Force and the Healthcare Task Forces to do some policy and advocacy work in that context. I'm going to introduce Dr. Brunette now. She will follow my presentation. Dr. Brunette is an addiction psychiatrist at Dartmouth-Hitchcock Medical Center. She is an associate professor at Geisel School of Medicine. She also is medical director of behavioral health services for the Bureau of Behavioral Health of the state of New Hampshire. And she is a researcher who researches diverse topics, but has a focus on innovative approaches to treatment of tobacco use disorder and treatment of substance use disorders in people with severe mental illness. And she works on clinical trials, psychosocial research, as well as technology research for the Center for Technology and Behavioral Health. So I'm very honored that Dr. Brunette has agreed to present with me. Before I start, we would love to know a little bit about you all. It's too big a group to do introductions, but I'd like to get a sense of who's in the room. So I'm wondering if you are primarily an addictions-related counselor. Your focus is on counseling on addiction or psychosocial therapies. Could you raise your hand? Okay, so that's a lot of people. How about mental health counseling? I know there's crossover, but if it's, okay, primary training in mental health counseling. How about general health care, nurses, doctors who don't specialize? Aha, so primary care people? Okay, so great. So many people involved in transition care. How about people who are administrators or policy people? Okay, thank you very much. What did I miss? Yes?
Integrated behavioral health.
Integrated behavioral health, wonderful. Okay, but we need to see more of that. Yeah.
Higher education.
Higher education, wonderful. Okay, so thank you. It seems like there's a nice mix of people here. We're going to present, because we're recording this, what we thought we would do is try and do our presentations, each of us speaking for 35 or 40 minutes, and then have at least 10 minutes at the end for discussion. Because we're recording, if we can hold comments, thank you very much. Yes. If we can hold comments until the end, after Dr. Brunette speaks, that would be great. Unless you can't hear us or there's something that you really need to respond to. You're trying to tell me something.
Microphone?
Oh, can people at the back not hear me? Should I use a microphone?
I think,
Okay.
the room's pretty full.
Okay. I just want to make sure this is, just figuring out the technology, and then we'll be here. Well, thank you very much. Okay, I appreciate it. Okay, so as we're all aware, and somebody mentioning integrated behavioral health, most of us are aware that really for the last century, at least many decades, behavioral health care has been carved out from our general health care system. And so when we encounter people who have substance use disorders, it's often in a context where not ideally suited to taking care of them. And therefore, we often feel inundated by challenges associated with their presenting to our clinics. And when we think about the challenges and ask people about what they're confronted with, often it falls into three categories. There are patient-related issues, there are clinician-related issues, and then there are systems issues. So for patients, we'll often find people who are very distressed, or they may be intoxicated or in withdrawal. They may have difficulty making appointments, and sometimes if we haven't identified that there's a substance use disorder behind that, we ourselves become challenged with their distress, not knowing what to do for them. So patient-related challenges that we encounter, and then many of us are not prepared. Certainly those of us who went to medical school or nursing school decades ago didn't receive much training, and to the present time, not a lot of training in evaluation and treatment of substance use disorders or other behavioral health problems. And then there's a lot of stigma, so we may have attitudes that are hypercritical or not appropriate, or we may see it in others. I think most people in this room who have enough interest in coming here are really engaged in trying to solve these problems. But we may notice our colleagues who have stigmatizing or disrespectful attitudes towards some of the patients that we're trying to treat, or when we encounter problems time after time again, and we're not able to address them effectively because of systems problems or preparedness problems, we may get compassion fatigue for trying to help people in a context which we can't do the best that we would hope that we could do. And then finally, the systems gaps. We often don't know where to refer people. It hasn't until recently been easy to find a single source for getting referrals to treatment. Now, NewHampshireTreatment.org is up, and 211 is getting prepared to provide resources. It's a bit easier, but for a long time, it's been hard to find those resources, and still is. We don't have enough resources in all levels of care. Then there are lack of integration, but we're working towards that. That's what the DISRP is about, and hopefully with hubs and spokes evolving, we'll have a better integrated care. And I know different health systems are working on bringing mental health and addictions providers into general health care systems so that we can screen and actually have somebody someplace to send people. And finally, our electronic medical records or our record-keeping systems haven't often helped support these. So we are challenged, and in order to transform our systems to better serve people with substance use disorders, we really need to work at the level of caring for the patients, for preparing providers, and for transforming the system itself. So that's our challenges, I think, as a group. You may have others, and please identify them when we have our discussion. But when we look at how substance use disorders are affecting the country, what we see here is going from 2005 to 2015. At the top, we have this blue line, which traditionally has been the most common substance use disorder. This is the TEDS, the treatment episode data system that tracks the primary diagnosis that patients give when they come for substance use treatment. So if they identify alcohol, they're coded as alcohol. Cannabis, they're coded as cannabis. Opioids as opioids, etc. So here we have alcohol traditionally having been 40% of the treatments presenting across the U.S. We see that trending downward ever so slightly in the around 2009 to the present, very slight decline. And then starting if we went back to the 90s, we would start seeing opioids climbing, and by the time we get to 2005, we see that they've continued to climb as a reason for entering treatment. And then in 2015 across the U.S., opioids exceeded alcohol, which is really a landmark, and a negative landmark for all of us, I think. Cannabis here has held fairly steady across that time. When we look at New Hampshire, it's a different type of chart showing us the percent of people demanding treatment for different substances. We see, and this is in 2016, opioids really exceed alcohol here, with almost 60% of people citing opioids as a reason for seeking treatment. Most of that is for street opioids, that's heroin and fentanyl, carfentanil, what people find on the streets. And alcohol is second. Then we have cannabis, which seems to be rising across the state and across the U.S. as cannabis becomes more available, cocaine, amphetamine, and others. So when we look at drug overdose trends, that was treatment demand. We see across the U.S. from 1999, and if we went back starting in the 90s, overdoses going up. Most of these are opioid-associated overdoses. And then we see starting around 2012, a real uptick, and then in 2014, 15, really steep incline. So what's going on there, if we look a little more closely, is that the increase started with prescription opioids, which are labeled here as natural and semi-synthetic opioids, which increased and increased until about 2010, then began to level off and had a gentler slope up. But what happened around the time that prescription opioids were leveling off is heroin started increasing. And then, in about 1913, we saw a massive increase in fentanyl and carfentanil. It's important for people to know that when we talk about fentanyl that's available on the street, this is not diverted analgesic fentanyl. There are patches that people use. There are transmucosal lozenges that are used primarily in cancer pain, but in other types of pain as well. It's not diversion of those. This is fentanyl that's being manufactured in China, Colombia, and other countries and imported in volumes. And so because it's 50 to 100 times more potent than heroin when it's first introduced in the street, and still people can't titrate what they're using and would often unexpectedly get fentanyl and overdose as a result. Now it's, for many people, a drug of choice, but it still is associated with increased deaths. So in New Hampshire, we know if you look at these dark states, we are in the highest quarter of opioid overdose deaths. We've been in the top 2 to 6 for the or 1 to 6 for the last several years. We went down to 6 from second last year. And then this is just a curve from 2008 to 2017 of New Hampshire drug deaths. It looks like we are beginning to level off, and you've probably heard that projections are that we're actually going to decline this year. I think we still need to work as hard as we can in every intervention we can think of to keep this trend going, but there is some light at this point, perhaps. So why should we care? I think everybody in this room, because you care to come to this, know why we should care. Because this is not other people. This is us. This is our families. This is our neighbors. It's our community members. It's our colleagues. I have never been in a room where somebody didn't know someone who was affected by some kind of substance use disorder in a life-threatening way. Is there anybody here who's never met anybody, never known anybody? No, not a soul. So it's all of us. So we know that there are many different reasons that people use substances. Curiosity and experimentation, what does that feel like? Why are so many people using it? Often, some people will use and they'll enjoy it, and whatever the substance is. Alcohol is legal in our society, and there are plenty of people who will electively use alcohol from time to time or fairly regularly, and be able to use it without adverse consequences. Cannabis use is becoming more common. All of them have potential for harm. So elective use, curiosity, and experimentation with a wide variety of drugs can occur. Some people who use substances for any of those reasons will find that they actually change the way they feel in ways that might, at least initially, feel good. So if somebody's really anxious and they're using an opioid for pain, and they say, hey, I don't have pain now, but I'm feeling really anxious, so let me take a little bit of that. Or they slept better initially when they were taking whatever substance, alcohol or cannabis or opioids, so they use it for sleep. People who have PTSD or traumatic memories may feel a little bit better when they use those drugs. The challenge is that after a while, the ups and downs of the drugs actually create more distress for people, and we usually have much better treatments for all these symptoms. But of the people who use substances for whatever reason, a certain percentage will develop the disease of addiction in association with use of the substances, and we'll talk more about that. So all the drugs that we use to feel good, whether it's alcohol or cocaine or cannabis, that give that temporary high, act on a really ancient part of the brain called the limbic reward system. The ventral tegmental area and the nucleus accumbens are two of the key centers associated with that area. And these drugs act on that center and they cause release of dopamine and they make us feel good. These are ancient centers that are very necessary for survival. So when you eat a good meal, or when you're hungry and you eat pretty much anything, it feels so good, so satisfying. You're releasing dopamine and that's making you feel good. If you're really, really thirsty and you just dream about water, you need some so badly, and you take a drink, it's very, very pleasurable. Sex, it's necessary for survival of the species, so it feels really good. So they're very potent and important survival mechanisms in our brain. Fortunately, most of us have an intact inhibitory system, starting in the region of the prefrontal cortex. It's our executive command center, and it tells us, well, you've had a drink, you had a nice time with your friend, but it's time to go home and be with your spouse. Or you have to study, or you have to get up the next day for your job. So you're not going to have 2 or 3 or 4 or 5 and then drive home. So our executive command center is often called the stop center, where the limbic reward system is the go. So there's this interplay between stop and go. Most of us have experienced it sometime or another. Going through that. So in terms of dopamine release, we talked about it. Those natural rewards cause about, say food, causes about 150% increase. So 2.5 times the dopamine when you use that. Sex, 200% increase. Alcohol and morphine, about 200% increase. Then you get up to cocaine and methamphetamine from 4 to 10, 1,000% increase, 400 to 1,000% increase. So pretty remarkable increase in that dopamine. I showed this the other day and somebody said, alcohol causes as much dopamine release as sex? I don't believe it. But anyway, that's what this study says. So choose your reward. If we look at this, most of us are like, except it's after lunch, so you probably don't feel anything but satiety, you feel full. But if you were hungry and you looked at this, the hamburger, the ice cream cone, chocolate cake, maybe tofu and vegetables, I don't know, beer, wine, look pretty good to many of us, and we would enjoy them. So we all have that experience of reward, no matter what it is. Oh, sorry, the slide didn't fade in the way it's supposed to be, but we all have perfect control, right? You can eat 1 potato chip, you can eat a small ice cream cone, or half glass of wine. None of us have ever seen the bottom of a bag of potato chips, or Ben & Jerry's, or maybe woken up with a hangover. I think most of us have had one of those experiences at least. So has anybody not ever had more than one of the potato chips they wanted, or more than the ice cream they wanted? See, nobody raises their hand. So we all know what this interplay of stop and go is, reward and inhibition. So if these rewards are so good and our inhibitory systems are so imperfect, why don't we all develop addiction? So that's a good question. So we understand that addiction, in part, is related to biogenetic predisposition and drug exposure, or at least historically we have thought that. So we know that for alcohol, there is an important penetrance of the development of alcoholism or severe alcohol use disorder with biogenetic predisposition. But people who don't have a biogenetic predisposition can develop substance use disorders as well. And one of the things that we've noted is that as people are using higher, more intense doses of rewarding substances, such as high-dose opioids or injected fentanyl, that there seem to be people who are actually developing addictive disorders who don't have that biogenetic predisposition. And then we've historically thought that personal psychology, so the presence of anxiety or depression or adverse experiences and sociocultural milieu, prime the way people use substances, but weren't necessarily part of the addictive disorder. But what we're finding now is that serious trauma, inescapable repeated stressors, adverse childhood experiences all seem to prime us physiologically to develop addictive disorders. So even in the presence of a low biogenetic predisposition and the presence of high traumatic experiences, either as a child or later in life, we seem to be primed to develop an addictive disorder with repeated use of drug exposure. We've always known that personal psychology, social and cultural milieu are important to recovery. Now it's clear that intense stressors are associated with the development of addiction. So when people develop addiction, a number of things happen. Here's that ancient part of the brain, the limbic reward system. But that system, as we talked about, begins to erode inhibitory control. It begins to hijack the brain. That was a term that was coined by Ellen Leshner, a former chief of the National Institutes on Drug Abuse, the hijacked brain. And it really describes how different centers of the brain come under the control of the limbic reward system. So all motivation and drive, which used to say, I want to get ahead, I want to shelter my family, I want to pass some tests. No, it's more important to feed that limbic reward center. That part of the brain has hijacked motivation and drive. Memory and learning starts serving. You pass somebody you knew on the street you used to use with. You're 2 months into recovery and you're just going to put your blinders on. But the memory triggers an intense drive to use. So memory and learning, people, places, and things can then play into the continuing drive to use. Withdrawal, physiologic withdrawal, is part of in somebody who's developed an addiction, an unpleasantness that may lead them back, but in and of itself is not the whole picture of addiction. And finally, there's recent research looking at the insula, which is a part of the brain that sort of screens. It's a command center for bodily sensations and external environment coming in and screening for what's important or what's relevant at different times. And that comes under control as well. So the brain is really set up to feed that limbic reward center. We know that there are protracted changes in the brain of people who develop an addiction. This is an old slide, but very representative of what we see. This is a healthy brain. This is a functional MRI looking at blood flow and oxygen consumption in the brain. And somebody with no drug use, there is a lot of activity. In somebody with cocaine addiction, 10 days without cocaine. So that's, they're not using the cocaine and it's causing the blood vessels to shut down and show these areas of non-perfusion. But this is just showing that the brain has remodeled itself in the presence of cocaine. And this occurs with other drugs as well. And then looking 100 days out, we're beginning to get more activity in there. But they're really protracted changes. So when we're trying to understand why somebody isn't getting what we're trying to work with them on recovery concepts or trying to get them to use their medications as suggested or think differently about their lives, sometimes it's really hard because your brain is not the way it was when it was healthy over here. So it takes time. So diagnostic criteria for opioid use disorder are many. This is from DSM-5. I'm not going to go through all of those, but just to make the point that if you look at the first 9 of them, they're really all either drug-related or functional. So the relationship to the drug, wanting to cut down, taking more than you intend, using it longer than intended, or craving the drug, or not being able to fulfill obligations that you have to other people, missing appointments, just not functioning in the way that you would without the drug. Are criteria. The last 2, tolerance and withdrawal, as I mentioned before, withdrawal and physiologic dependence are present in many people who have addictions, but for some drugs they aren't. And they're present in people who are using medications such as benzodiazepines or opioids. And so DSM-4 says the criteria are not met if you're taking the medication as instructed or you're taking it under medical supervision. That does not count as a criteria for addiction. Okay? So these number of criteria that you meet are put you either mild, moderate, or severe opioid use or substance use disorder. This is virtually the same for other substances. There was slightly different wording. I'm sorry, this is a little dark here. But a typical pattern of substance use is not uniform. People don't have the drug, they have to go out and get the drug, they use the drug, they get very high, then they spend time recovering from it as the drug levels plummet. So if we look at this, this is time, this is plasma concentration, the drug is in their body, and they're up in this high reward, feeling euphoria, good, and then they fall down, and then while without the drug, up and down. And in here is the only time that they're awake, alert, feeling normal, and composed. So they're in a process of either experiencing the effects of the drug or experiencing effects of the lack of the drug. And what this can do can lead to all kinds of behavioral changes, as we observe. So drug effects are variable. So if you're taking opioids or cannabis, you may tend to be calm or placid or kind of sleepy or out of it, along with euphoria. But if you're using cocaine or amphetamine, it's a very different kind of behavior associated with it. Because along with a high, you're feeling tense, agitated, a lot of energy, and it can lead to violent behavior in some people when they're crossed in that state. Withdrawal tends to be physiologically the opposite. So people who are using opiates, for example, when they withdraw, there's a lot of restlessness, agitation, they may be walking, they can't sleep. People who are coming off of an extended high from cocaine or methamphetamine, they sleep for days. They'll be very kind of down and low feeling for a period of time. So that's important to understand that people use combinations of drugs. So it may not always follow these classic highs and lows. They use drugs in combination. And behavioral effects may vary with dose. So for example, we're probably familiar with people who use alcohol. They may get very disinhibited with one drink and be more active and animated, and then they keep drinking and they get very stuporous and sleepy and hard to arouse. So it's variable responses. But when people are in that craving state, their drug levels are low and they're wanting the drug, it can lead to behaviors that person typically would not exhibit. They can lie, they can manipulate, they can steal, trying to get money or trying to get drugs. I've had people say that they stole from their grandmother's important jewelry, sold a train set that had been given as a child that was their most valuable possession. I'm sure most of us who work in the field have had people talk about that. So often there's a sense of shame or a sense of failure or inner loathing that develops because that's not me. I did that thing, but that's not me. And so that can occur as a result of drug use and withdrawal and craving. When we're being challenged by people who are behaving in those ways, and maybe they're not, we have a great relationship, so we're talking about it, or they may be confrontational with us, or aggressive, or angry. And sometimes we all have bad days in trying to serve people. I find it really helpful to think about what did this person go through to bring them to where they are now. And each one of us started out just like this, vulnerable, and what happened to create those challenges. So usually there's a narrative there. So addiction, once it is in full bloom, has impact on all kinds of dimensions of an individual's lives. Most people develop functional disabilities. They can't at some point in the course of the disease, if it goes unchecked. Thank you. They can't participate meaningfully in social activities, or they may start missing work. They don't enjoy the recreational things they did before. They're at risk of harm from their substance use. Because of the functional losses, they may have increased stressors, financial stressors, relationship stressors. They can't sleep. They start thinking. We talked about thinking differently about yourself. Some of the shame and blame that goes along with it. Anxiety and depression are nearly ubiquitous among people who have an addiction, and many secondary medical problems can occur. So, it's important in putting this into perspective that addiction is not so different than other chronic diseases, if we think about it. About 10% of us will develop an addictive disorder over the course of a lifetime. The etiology, like diabetes, asthma, and hypertension, biogenetic predisposition is often part of the disease, and then behaviors contribute to it. So diabetes may develop because of a strong biogenetic predisposition, but overweight, lack of exercise, high sugar consumption may contribute as well. So, and similarly with heart disease and other medical conditions. The course of these chronic illnesses is one of remissions and exacerbations, so they'll get worse and they'll sometimes get better. We've changed the language in substance use disorders to relapse and recovery. I'm not sure why, but it's really remissions and exacerbations. All these diseases are life-threatening if they're not treated appropriately. So it's really important that we address them when we suspect that they're there. You know, 15 years ago when we talked about these issues, people just swept substance use disorders under the rug. If somebody heard that a patient was drinking 6 or 8 drinks a day, they'd say, well, your blood pressure's high, let's put you on some medication, and that would be the approach to it. Fortunately, we're beginning to recognize the life-threatening nature, and it's all of our responsibilities to address them. Treatment and recovery are similar for addiction as other chronic diseases. Most chronic diseases, we don't just put a person on a medication. We'll say diet, exercise, very, very important. In this case, avoiding the substance to which somebody is addicted and or other substances, or moderating use is an option for some people. For most people, abstinence is a goal, not for all. Engaging in counseling, and then self-regulation, cultivating a healthy lifestyle. And then pharmacologic interventions can be very important. With appropriate wraparound care, recovery is present in about 40 to 60% of people at the end of 1 year. Unfortunately, most people don't get intensive wraparound care at the level that's required for their particular stage of the disease. But similarly, with other chronic conditions, adherence to medications is 40 to 60%, depending upon what disease you're talking about. And adherence to behavioral change in hypertension and diabetes has been shown to be less than 30%. So it really is very similar. And adherence is lowest in people who have less resources, less socioeconomic support, poor family or social support, and psychiatric comorbidity. So similarly, it's difficult. We know that recovery approaches, we've talked about most of these, but some of the evidence-based counseling supports like CBT or ACT have become important. Peer support is developing a strong evidence base. We've known collectively that AA and NA have been very, very helpful to people over the years, but now we're studying group-based peer support and individual peer support, and they're very, very valuable in recovery. Exercise and meditation, interestingly, self-care, have been developing their own evidence base, each of them to support physiologic changes, reductions in craving, reductions in relapse. Clearly healthy social networks are important, and meaningful engagements, employment, volunteerism, things that give meaning to a life are important. Timely care, recovery-oriented care, so people supporting recovery so people don't cycle back into treatment time after time, respecting people's individual values, their cultures, their preferences in terms of treatment, and importantly, again, treating co-occurring disorders, mental health disorders, and other medical issues is important. So, I'm going to end with talking briefly about pharmacologic therapies for opioid use disorder. We've seen this before, this graph before, looking at the erratic way when people use opioids. Let's say this is injection opioids, getting high, being in withdrawal, getting high. When we introduce a long-acting opioid or a partial opioid, methadone is a long-acting opioid, buprenorphine is a partial opioid agonist. When we introduce these, we get a different pattern of ups and downs. In fact, we keep people in this normal, this homeostasis level for longer periods of time, and when we overlap our doses appropriately, depending upon which medication we're using, we keep somebody right in this normal feeling period. They're not high, they're not nodding out, they're not sleepy, or they're not in withdrawal, craving, and drug seeking. So this allows people to engage in whatever their recovery program is, engage in a rich and rewarding life. that's the goal in most situations. So, medications. We have 2 opioid agonist treatments now. We have methadone, which is a full agonist. That means it binds to the opioid receptors, turns them on quite fully. It's highly regulated, and it's dispensed through clinics. Because it has a very long half-life, and it's very risky if misused because it can accumulate very easily. It also, in high doses, can cause cardiac arrhythmias. So it's very regulated in its use for addiction treatment. And then buprenorphine is a partial opioid agonist, binds to receptors and partially turns them on. So there's not as much respiratory suppression, there's not as much of a high for most people, but it keeps people from going into withdrawal, and it can keep them from the peaks and valleys that we talked about. It's available, as you know, by prescription, 8 hours of training for physicians, 24 hours of training for nurse practitioners or physician's assistants, and there's less use, so it can be prescribed either weekly or monthly, and there's less risk when it's misused. Though, if people are using benzodiazepines, or if people start injecting it, or they're using it in combination with other substances, overdose is possible. So it's not 100% safe. Now, the importance of these medications is really clear in studies that have been done. This was a review that was done in 2014 that looked at all available evidence, and what they found, their summary was that without opioid agonist therapy, 90 to 90% of people relapsed within months. And this is a life-threatening illness, so back in the street with opioids, less tolerance to the opioids, very significant negative outcomes. There are subgroups who may do better because of really wraparound treatment, lots of carrots and sticks involved in it, and good social support. Subgroups can do better. But until we really have a handle on who's going to do well without opioid agonist therapy, it is the standard of care for treatment of moderate to severe opioid use disorder. So with opioid agonist therapy, 66% of people are in treatment at 1 year. Some of them may be using on a less addictive, less harmful pattern. But it's clear that there's less morbidity, less death, greater employment, better social service, social interactions, and fewer healthcare emergencies for people on opioid agonist therapy. So a lot of people say, isn't this just substituting one addiction for another? Well, the person is physiologically dependent, yes, but if we recall, the criteria for opioid use disorder don't include physiologic dependence if it's a prescribed medication. It's the functional criteria that we want to look at in the drug relationship criteria. None of the functional criteria are there when people are using opioid agonist therapy. So, there's one other option that is an emerging option, but where it's going to be positioned and we have good data in is not clear. Naltrexone is an opioid antagonist. It has none of the effects of opioids. It's clinically available both orally and by injection for opioid use disorder. It's used pretty exclusively after induction by monthly depot injections, so that people don't have to make a day-to-day decision whether to use it. It blocks opioid effects, so if people use early in recovery, which sometimes happens, they don't get any opioid effects, so it's not reinforced. It also seems to block craving to some degree, and it doesn't have the risks associated with misuse of opioids. So there's emerging evidence, and we just don't know where that's going to end up. There was a large multi-site clinical trial that was done with almost 600 patients that showed that once people were induced onto naltrexone, their outcomes seemed to be about the same in terms of craving, in terms of opioid relapse, use of other substances, depression, and a number of other variables. But that's just one study, and I think most of us would say, for now, for most patients with serious opioid use disorder, that buprenorphine is the drug of choice. But we will see over time. This may be a good option for some populations. We'll see. So we're trying to expand access to MAT. Traditionally, it was intended in 2001, when it was first permitted, that it would be done in primary care. That didn't happen, and we got a lot of specialized clinics, mostly addiction psychiatrists, other psychiatrists, and specialty clinics would use buprenorphine. But now there is more movement towards primary care, and we know last year 400 clinicians in New Hampshire were trained through MAT trainings, and we're beginning to see it much more available in primary care. Emergency rooms and inpatient units are sort of the next wave because we see people coming into the ER in opioid withdrawal and then leaving without treatment. But there's a huge move across the state to begin to engage people in emergency rooms and in inpatient units. Prisons are another place where MAT is beginning to emerge, first with Naltrexone, but there are some pilots in our state that are being talked about that would bring buprenorphine into jails and into the corrections system. I'm just going to end with this slide for us all to remember that just as there's a continuum of use, clinical use, risky use, misuse, to overdose, there are roles for all of us who work in healthcare at each of these levels. Optimum pain treatment, best opioid practices when people need to use opioids, routinely screening and referring people for treatment, using motivational interviewing to move people along that continuum, prescribing or referring people to pharmacologic treatment, supporting recovery when patients are in recovery, asking about it and supporting it wherever we can, and then all of us carrying naloxone because we all can be ready to intervene if needed. Oops. So I'm going to end there. And Dr. Brunette will come on.
Do you want me to use this?
Yeah, it's better to turn the switch all the way up.
Okay, can people hear? Okay, why don't everybody stand up, stretch, wake your body up. I have the unfortunate job of trying to keep you awake. I was telling Seddon about one time I had to give a lecture after lunch, and somebody in the front row fell asleep and started snoring. And that was the boss of everybody else in the room, so nobody wanted to wake her up. So I had to give a lecture while someone was snoring. Okay, all right. How do we get going here? No.
No, I'm so sorry. I'm so sorry. My bad.
Okay. This is a picture of Lake Ontabago. How many people have been to Lake Ontabago? It's gorgeous. All right. Okay, it'll take a minute to load. So my job is to talk with you. Do I really have to talk into this? It sounds terrible.
You don't have to.
I don't have to.
I'm gonna pause. Can people hear me if I do this?
All right. Okay. All right.
It's up here.
Okay, now I remember the slide that I wanted to switch. Okay, so my job is to talk with you about alcohol, marijuana, and tobacco. So those are the most common substances along with opioids. You've already heard about opioids, so I'm going to talk about the other common ones today. I'm going to tell you about their epidemiology, how common are they, then we're going to talk about comorbidity with mental illnesses. I'll talk with you about how common that is. I want to talk with you about the health consequences, and then how do you screen, assess, and treat. And I'm going to focus on the pharmacologic treatments today, and then we'll wrap up and do questions. Now, when I talk about this stuff, I like to get you to think about a case of a person who has a substance use disorder, because I think it's easier to remember stuff when you think about a person who has the issue. So I'm going to tell you about MAPS. MAPS is a composite of different people that I've interacted with. So imagine that you're a primary care provider, and Max is your patient. Max is a 32-year-old single man who works as a chef at a nice restaurant. He comes to you with a bad sprained ankle. His blood pressure is elevated, and he smells faintly of alcohol and of tobacco. He says he fell last night coming home from the bar. His family history is significant that he has a father who died of a heart attack. His mother has diabetes and depression. And His substance history is he started drinking at age 16. He used cocaine heavily when he was in college. Smokes marijuana occasionally. He smokes 10 cigarettes a day. So think about him, and now we'll kind of think about the prevalence of these substances in general in the U.S. I'd like to show this slide so you can see the proportions of people with lifetime substance use disorders. Here on the right, at the time this survey was done, this was the National Epidemiologic Catchment Area Study. At that time, a lifetime history of any substance use disorder was 15% according to that survey. It was a pretty conservative survey that gave fairly low prevalences. But if you had a serious mental illness, you had a 1 in 2 chance of having any substance use disorder in your life. If you had a mood or anxiety disorder, you had a 1 in 3 chance of having a lifetime substance use disorder. What this doesn't show is if you have one substance use disorder, you're way more likely to have another one. So there's comorbidity between substance use disorders as well. Can't remember which thing does what here. All right. Am I going in the wrong direction?
You have it upside down.
Sorry. So a lot of you folks here are addiction treatment providers. So think about if you're working with people who have addiction, how likely is it that they're going to have a mental illness? So in the community, if you're an outpatient provider, 1 in 4 of your patients will have a mental illness. If you work in a hospital or institution, over half of your patients with addiction will have a mental illness. If you work in a substance abuse treatment facility, residential, 2/3 of your patients will have a mental illness. So we all need to get out of our silos, thinking that we just do one or the other, and we really need to open our minds to the reality that whether we think we're a mental health provider or an addiction treatment provider, we're going to be working with people who have both. So, we just have to accept that and recognize that that's what we're doing. So let's think in a little more detail about who is most likely to present with a substance use disorder. This is data just showing alcohol use disorder from the NESARC survey. This survey was more lenient, so in this survey, more people had a lifetime substance use disorder. About 1/3 had an alcohol use disorder. And it's more common among young people. Look at this, young adults. Over 1/4 of young adults met criteria for having an alcohol use disorder. And then it's less common as people get older. More common in men than women. That's the case pretty much across the board for substance use disorders. And there's some racial and ethnic differences for alcohol in this study. Native Americans more likely to have substance use disorder. Sometimes there's urban and rural differences. Alcohol use disorder is more common in cities. This shows you tobacco, the other ubiquitous substance use disorder that we like to just forget about, but it's one of my pet peeves. So think about tobacco. In this survey, they looked at tobacco use disorder and comorbidity with mental illness again. My color in these slides didn't really show. The gray bars here are the prevalence of being a daily smoker. And this grouping is people without a mental illness. So about 12% of people without a mental illness were daily smokers. And among those who had ever smoked, almost half had quit. So a lot of people had quit. The middle grouping is people with a mild to moderate mental illness. About 20% were smokers, and fewer had quit. This grouping is serious mental illness, schizophrenia, bipolar. Rate of smoking is even higher. Over 1/3 were daily smokers, and the prevalence of quitting was even lower. So the idea here is if you have a behavioral health disorder, mental illness, or other addiction, you're more likely to smoke, you're less likely to quit. So tobacco is one of those other comorbidities we just need to think about. Okay, so in summary, there's a lot of comorbidity out there. We need to open our minds and be thinking that we're going to be, when we're working with people with substance use disorders, we need to be thinking about mental illnesses as well. So what are the health impacts? I have a cartoon up here for alcohol. So how many drinks did you have last night? How many drinks did you have every night this week? If you're a man, if you had 2 or more drinks that's a problem for your health. If you're a woman, it's only one daily drink, and you will have harms happening in your body over the course of 20 years. So this is long term. If you look at health consequences for alcohol, alcohol is harmful to every organ in your body. So you need to moderate. If you're a man, it needs to be less than 14 drinks a week. If you're a woman, it needs to be less than 7 drinks a week. If you don't, what happens? Starting from the top, hurts your brain, you're more likely to get dementia, hurts your nervous system, you can get neuropathies. Everybody knows it's really harmful to your liver. You can get hepatitis, liver damage, and liver disease. It goes on and on. Your heart is another big one. Your heart and your blood vessels are harmed by alcohol. That's why people who have alcohol use disorders, they all have hypertension. You know, if you have an alcohol disorder clinic, you might as well just bring in a primary care person to treat all the hypertension, vascular disease, and so on. So because alcohol is so toxic to the body, people with alcohol disorders they're going to primary care. So primary care clinics are seeing a lot of people with alcohol disorders. This was one of the surveys, 20 to 35% of patients showing up in primary care have an alcohol disorder. That's a lot, that's 1 in 3, 1 in 4. So we need to be treating this in primary care. Okay, what about marijuana? Marijuana is so popular these days. So we have medical marijuana in this state, legal marijuana all around us. Lots of people are starting to use more marijuana. If you're thinking about the health impacts of marijuana, though, you have to think, what do you mean by marijuana? So the two main ingredients you want to think about are THC, which is what we all think about when we think pot. THC is the primary addictive component of pot. Okay? And THC can increase paranoia and anxiety. In contrast, there's cannabidiol. That's the other large ingredient in marijuana. That, in contrast, is not addictive and may reduce anxiety. Now, the pot that you can get on the street now is not the pot that you could get on the street when I was a kid. The amount of THC in street pot has gone up, it's tripled, quadrupled, maybe even more since the 60s. And the amount of cannabidiol has gone down and is basically zero in street marijuana now. So the stuff that kids are buying on the street, or whoever's buying on the street, is stronger, and it's mostly THC. So it's going to have more of these mental health negative effects. And you also have to think about, well, what are people using? There's the weed, or the plant material, but now people are getting, they're buying cookies with THC in them, the so-called edibles. They're buying all kinds of concentrated products, and they're dabbing it, they're vaping. So it's a new world, and it's really easy to eat a whole cookie that's has 100% THC in it, and then they're in the ER or they're jumping out a window because the THC's gotten them psychotic. So just to harp on another one of my pet peeves is, why are we not regulating the amount of THC in medical marijuana in this state? Why can you walk in one of those stores and buy products that are literally 99% THC, that if you took one bite out of it, you'd go nuts. Anyway, so how does cannabis use disorder impact health? Well, for short-term impacts, sorry this text is so small, I'm sure you can't see a thing here. Short-term effects: impaired short-term memory, impaired motor coordination, altered judgment, and psychotic symptoms in people who are vulnerable. So people can't learn as well, they can't drive as well, and their mental health is not as good. Those are short-term effects. What about for regular users, regular long-term or heavy users? If you use a substance regularly, some of us will get addicted to it, and about 10% of people who use marijuana will end up with a marijuana use disorder. Those rates are higher among young people. About 20% of young people who start using pot in adolescence are going to develop a marijuana use disorder. It seems to alter brain development. It's associated with poor performance in school. cognitive impairments and reduce life satisfaction. And if you smoke pot, it has a negative impact on lung function. People develop symptoms of chronic bronchitis. Smoke is bad for you, whether it's marijuana smoke or your campfire smoke or cigarette smoke. Okay, and if you start smoking pot when you're 12 and it's high THC pot, you're more likely to develop a chronic psychotic illness like schizophrenia. Not good for young people. This slide just shows you that what I told you, that increasing percentage of THC in pot you buy on the street, and then related to that, increase in ER visits for problems with being really high from marijuana. I think there's copies of these slides out there for people taking pictures. And we will post the slides after the lecture so you'll be able to see them. What about tobacco? Can't forget tobacco. Smoke, as I said, has a lot of toxins in it. Tobacco smoke has hundreds of toxins, and this cartoon shows you some of the toxins in smoke. This is a nice picture of a tailpipe coming out of a car, just to show carbon monoxide in tobacco smoke is the same stuff coming out of your car that some people drive into their garage, shut the door, leave the car, and try to kill themselves. That's what kills you. That's what people are breathing in small amounts in their cigarette every day. And those toxins are also harmful to many parts of the body. We all know cigarette smoke causes cancer and lung diseases, but also cardiovascular disease. Bad for your vessels, bad for your heart. It also contributes to developing diabetes, poor healing after surgery or injuries. Lots of harms from the smoke. In contrast to the nicotine. Nicotine in general is thought in the amount in cigarettes to not be harmful. It does increase blood pressure and increases pulse. So if you smoke and you have super high blood pressure, it's going to go up, and that's not good. But overall, it's a stimulant. But in the amounts in a cigarette, it's not thought to be harmful. Nicotine is a toxin. If you drink a gallon of it, you will die. But in the tiny amounts that are in a cigarette, it's not harmful. So nicotine replacement therapy is safe. Smoke, harmful. Okay. So how do we assess people? When you think about Max, back to being, you're the primary care provider, Max came in the office. So when you're thinking about assessing Max or anyone, you want to be thinking about multiple substances. So you're going to ask about the substance that you're suspicious about, but you want to keep in mind, you want to ask about all substances, including tobacco, and over-the-counter medicines, since those are big these days too. You want to be thinking about psychiatric comorbidity. Do people have a mental illness that's going on? You want to think about suicide and violence risk and comorbid medical disorders. When you talk with people, even in your darkest moments, I want to encourage you to try to use a non-judgmental stance. Keep your mind open, keep your body language open, because people aren't going to tell you anything if they feel that you're going to judge them about their substance use. They've been judged by lots of people negatively about their substance use. So the more we can try to be non-judgmental, the more people will feel comfortable talking about what they're going through so that we can help them. Even when you use your most non-judgmental stance, some people just simply won't tell you about their substance use, and it's good to use other sources of information. Family members, friends, spouses, employers may want to share information about a person's detrimental substance use with you, and that can be really helpful. There's also the American Psychiatric Association and other professional societies are really recommending that we use standardized measures of substance use now. So for example, for alcohol use disorder, we could use the audit for adults and the CRAFT for kids. So we should try to use those, and then we can use those to follow people over time. They're also recommending that we use biomarkers now. We have a biomarker for all of the common substances now. For alcohol, there's the ethyl glucuronide. So this is a conjugate product of alcohol and glucuronide. It's present in hair and urine for 2 to 5 days after you drink. So this can tell you, has a person drank or not in the last 5 days. If you're wondering, is this person a chronic heavy drinker, we now have a biomarker for that. That's the phosphatidylethanol. That's a product of alcohol interacting with red blood cells, and it tells you that the person has been drinking heavily for at least a few weeks, so 2 to 4 drinks a day for a couple weeks. So if that's positive, you know a person is a daily, pretty heavy drinker. It takes a couple weeks for it to normalize, so once a person stops drinking heavily, you need to give them a couple weeks to clear. But this is a really important tool that's fairly recent on the market. For marijuana, we all know about urine THC. When people smoke pot, they take in THC and that will be in their urine. THC is stored in fat in the body, so it can take up to a month to wash out if a person's been a heavy marijuana smoker. But at least you can know that they were smoking it sometime recently. And for tobacco, there's breath carbon monoxide. So people can blow into a little handheld monitor, and that will tell you, it'll give you a breath CO level, high in heavy smokers, low in light smokers. And you can check for cotinine, which is a breakdown product of nicotine in the saliva and in urine. Okay, so once you've assessed a person and you've determined that they have a substance use disorder, that means they use regularly and they're experiencing problems due to their use and they're still using despite problems, then you want to sit with a person, talk with them about the problem and develop treatment goals. So you're going to provide education about the potential value of reduction versus stopping completely. Most people don't want to stop completely, and so you need to talk with them about the potential of cutting down rather than stopping. You want to elicit their preferences. Do they want to reduce their drinking or drug use, avoid drinking and drugging in hazardous situations, or stop completely? And then help them determine goals. This really helps develop therapeutic alliance. If people understand that you're interested in helping them set goals, they like that, and it provides a structure for shared decision-making about your treatments. You want to make sure that this discussion includes potential legal problems. Does this person have a DUI? That might require that they really should not drink at all. Are there home and work responsibilities that are being impaired? Are there children at home that are being impacted by intoxication? You want to make sure you review risk to self. Is there suicidality? Are there other risks to others that need to be taken into account as you're together working on treatment goals? So what happened with Max? Sorry you can't read this, but I'll read it to you. So after completing your assessment of Max's ankle, you ask him more about last night and about his drinking in general. He tells you he drank 12 beers last night, and that's what he does when he's out with his buddies. On all the other nights, he only has a 6-pack. He drinks those drinks at work, and then he drives home just after that heavy drinking. He says that several relationships have gone south in the past years. He had girlfriends who nagged him about his drinking so much that he dumped them. You note in his chart that he had high blood pressure at other clinic visits. He was advised to quit drinking, and he did not. You also note that his depression score is in the range of moderate depression, but he hasn't had any periods of abstinence, so you don't know whether that depression is substance-induced or whether he has an independent depression like his mother has. So you let him know that you're concerned about his drinking. You feel he has an alcohol use disorder. You also comment that he has depression symptoms, but it's hard to know whether those are caused by the drinking or whether those are independent. You advise him to stop. That's the healthiest thing he could do, is what you say. You ask whether he wants some assistance in changing his drinking. And you talk with him about the options. There's counseling, there's AA, there's medication, there's a combination of these things. After reviewing all those, he says, I'd like to try a medicine. I'm not a talker. So you advise him also to stop smoking and offer him assistance with that. And he says, no thanks. All right, so he wants meds for drinking. what are your options? Okay, so let's go over the options. The idea with pharmacotherapy for alcohol use disorder is that you're going to reduce the reinforcing effects of alcohol on the body so that when people drink, they don't feel as much reward or as much high like Dr. Savage talked about, and so they'll cut down. This is ideal for moderate to heavy drinkers like Max. This is not really necessary for light drinkers with problems. So you want to use it for people with current heavy use or whose drinking is so risky that you really want to help them cut down. People have to be motivated to reduce their drinking. The pill doesn't just obliterate the urge to drink. People have to try to cut down, and then the medication assists them in being able to control their urges to drink. This is also a good option for people who don't want to do talk therapy. A lot of people don't want to talk, so they'd rather try this. And it's for people who don't have medical contraindications to the meds. I'm going to talk about the 3 FDA-approved approaches, naltrexone, acamprosate, and disulfiram. There's a lot of other second-line options that are not yet FDA-approved for treatment of alcohol use disorder, but there's a fair amount of evidence showing they work. But I didn't have enough time today to go through everything. So let's talk about naltrexone first. This is, you already heard about this for the treatment of opiate use disorder. This is an opiate blocker. It turns out when you take a drink, part of the pathway that helps you experience reward from alcohol goes through the mu opioid receptor system. So if you block that, it blocks the experience of reward you get from drinking. There's good research evidence that this works. You can start this medicine while people are still drinking. They don't have to be abstinent to start this. It won't work for people who have a comorbid opioid use disorder, who need to be taking an opiate replacement therapy, because this is an opiate blocker. And it won't work for people who need opioids for pain. There's an oral form, there's a long-acting injectable form. For alcohol use disorder, you use the oral form. It's very easy to prescribe. Some mild side effects can make people a little sick to their stomach, or people have a little more headaches. Can't use it in a very low portion of people. There can be an increase in liver function enzymes, so it irritates people's livers. You have to draw that out. Some people take this. This seems to be most likely to be effective among people who have a family history of alcohol use disorder and people who have strong cravings for alcohol. So that's naltrexone. The other good FDA-approved option is acamprosate. This is a medication that seems to modulate the glutamate neurotransmission at metabotropic 5-glutamate receptors. It's thought to sort of calm a twitchy nervous system. It can be used when people have achieved abstinence. It's the way it was studied was that they wanted people to stop drinking, be clean for at least 3 days, and then start this medication. So that's a little trickier. It's also given 3 times a day, not as easy to take in that way either. Side effects tend to be mild: diarrhea, nervousness, and fatigue. It's not metabolized by the liver, so this is a good medicine to use for people who have hepatitis. And it doesn't interfere with opioids, so if people have a co-occurring opioid use disorder, this one works fine. This seems to work better in people who have anxiety, who don't have a family history of alcohol use disorder, who have late onset, and women. So, if you want to tailor your treatment, it might work better for those groups. And then the third FDA-approved option is Antabuse. This one's been around for, 40 years or so. This medicine stops the breakdown of alcohol such that a breakdown product called acetaldehyde builds up, and that breakdown product is toxic. It makes you feel very bad. So basically, acetaldehyde causes sweating, headache, shortness of breath, changes in blood pressure, palpitations, nausea, vomiting. It makes people feel very sick. So you develop a treatment agreement with somebody who wants to use this medicine, so they know if you drink while you're on this, you're going to be really sick. So you really need to not drink while you're on this. And then people agree. So it discourages drinking because people have this in their mind, a mental deterrent that keeps them, helps them say no to that drink when they're getting the urge to drink. This basically doesn't work very well unless a person agrees to be monitored and have somebody give them the pill each day and help them continue to take it even when they're having a bad day. So I wouldn't use this unless a person's in a situation where they want to be monitored and there's somebody who's willing to monitor them. It might be in a treatment program, it might be somebody's spouse or a friend. It's used, you take a daily pill, you start at a high dose and you take a lower dose. The half-life of this medicine is pretty long, so you can take it 3 times a week and it works fine. It doesn't have to be daily. It has mild side effects. It can irritate the liver, so you'd have to do blood tests and monitor people's liver function. It's best for people whose goal is complete abstinence, and again, they're willing to be monitored, so somebody will hand them that pill every day. Okay, so as I mentioned before, there's lots of other options. So what do you do if you prescribe a med, doesn't work? Well, you can try a different one, or you can switch over to a counseling approach, or you can combine meds. There's not great evidence that combining meds works. Nevertheless, if somebody's having a really hard time, that's something to consider. What about pharmacotherapy for cannabis use disorders? There's no FDA-approved option, but there are a couple of meds for which there's a little evidence for efficacy. One is this med, N-acetylcysteine. That's an over-the-counter supplement. That's been tested in teens, shown to help teens with bad cannabis use disorder. Another trial tested in adults and it didn't work. So, but because it's over-the-counter, it's quite appealing and easy to use. Gabapentin has also been tested for people with cannabis use disorder, and one study showed that it seemed to reduce cannabis use, people with cannabis use disorder. This is a pretty sedating med, but it's otherwise well tolerated. A lot of people really like it because it's so sedating. Some people really don't like it because it's too sedating. And then Navalone, a cannabinoid agonist, was tested and it did not work. How about tobacco use disorder? Again, you can use a replacement therapy for tobacco use disorder. The idea is when people stop smoking, they really go through withdrawal. And if you use nicotine replacement therapy, it's safe nicotine that helps people get through that period of withdrawal while they're changing their smoking habit. So you can use nicotine replacement therapy. It comes in multiple ways of taking it. A patch you put on your arm every day, gum that you put in your mouth, chew and park once an hour, or even better, the combination of both together. There's also inhalers and nose sprays. They're very safe. People worried for a while that, well, if people use these while they're smoking, the nicotine's going to be harmful. These guys did laboratory tests where they brought people who were heavy smokers into the lab. They put 3 patches on their arm. They had them smoke while they were hooked up to EKG machines in front of them. They did fine, but it did increase their blood pressure and pulse. But it's not harmful. They just removed the warning on NRT. You can use it while you're smoking. It's okay. If people feel sick from too much nicotine, you get nauseous, you feel dizzy. If you feel nauseous and you feel dizzy, stop smoking. Take the NRT out of your mouth, or you can take the patch off your arm. Okay? All right. What about nicotine replacement therapy through electronic cigarettes? These are very popular now. They're not FDA approved for smoking cessation, however. They come in many shapes and sizes. They are not monitored by the FDA yet. They will be in 2020 or 2022. It keeps getting delayed. But for right now, what you can tell people is, look, you can get your nicotine this way. You can replace through e-cigarettes, but we don't necessarily know what's in them, so we don't know just how safe they are. But in general, the ones that have been tested, the level of toxins in e-cigarettes, between 800 and 600 times lower than cigarettes. So these have vapor, they don't have smoke. So all those toxins in smoke are not in e-cigarettes, so it's probably a much safer way to get your nicotine. some people, you can combine it with nicotine replacement therapy. If people have bipolar disorder, it can stimulate mania, that's a problem. You want to probably, if people have mental health conditions, think about this, talk to a psychiatrist. Combine bupropion with NRT makes it much more effective. And then last, Chantix or Varenicline. This is a alpha-4 beta-2 nicotine acetylcholine partial agonist. When you prescribe it, you get a titration pack. You start a low dose, increase it. It's a nicotine product. It's stimulating. Some people feel kind of jittery on this medicine, but it is for sure the most effective med to treat people with nicotine dependence. It can cause nausea, a little bit of headache, and that jittery feeling. If people are feeling uncomfortable, you can lower the dose. A lower dose is better than no Chantix. It's not studied for use with kids. All of these tobacco treatments have some side effects, but I just want to point out, when people are quitting smoking, they don't feel good. And so when you look at these studies and you look at the rates of side effects, the people on placebo, generally, their side effects are pretty high, in many cases higher than on nicotine replacement therapy. So when people aren't feeling good while they're quitting and you're prescribing meds for them, keep in mind it's in part because when you're quitting you don't feel good. People don't sleep well when they're quitting. They have some nausea. 1 in 5 people has nausea. So keep that in mind, that generally using medications to help people quit makes a big difference, and it's try to help people tolerate them. Okay. So what happened to Max? All right, so you prescribe Max Naltrexone. You meet with him monthly for 3 months while he's trying to cut back. His drinking is reduced by about half. So instead of binging on 12 drinks, he's down to 6. On his regular drinking days, he's down to 3. His hypertension is better, but it's still there. He's a little less depressed. He doesn't want counseling. He wants to try to cut down more with his drinking rather than going on an antihypertensive medicine. So his goal is to cut down even more, and he's going to try drinking club soda in between each beer, and that's how he's going to cut down more. When you asked him about his marijuana use, he says he's actually cut down that now that you asked him about it, because he wasn't really noticing how much he was smoking before. When you ask him about his tobacco use, he says he kind of likes this whole getting healthier idea, and he's willing to try nicotine replacement therapy and call it quit one. So there you go. All right, so in summary, substance use disorders, they're common chronic conditions. They can be treated both in specialty clinics, but also in primary care. These people are showing up everywhere. They're in mental health clinics, and primary care clinics, and specialty clinics. Medications are helpful. They can be used in a chronic model. Think about, the person who got hypertension and uses a medicine for that. The idea here is substance use disorders are common chronic conditions. We can use medicines that really reduce the severity of urges people have to help them manage their chronic condition. Behavioral interventions are also effective and can be used in combination with meds, of course. And combined behavioral and pharmacotherapy is probably what you should try first with people with tobacco use disorder. With alcohol and marijuana, it's not clear that combining them first is the best or more effective way to go. That's what I have. We're going to wrap up here and take some questions. Thanks very much.
Okay, I wanted to say thank you very much. This was a lovely overview of those three. I'm going to leave right at 2:30, and I apologize in advance, but I have to be in Lebanon for something else at 4. So, but we're open to questions. I have one for you, while other people are thinking of questions. You can talk about NRT, nicotine replacement therapy, as a potentially lifelong treatment. And I've known other people, but you're a tobacco expert, so I'd love to hear you talk about that.
So the question was, I'll stand up so people in the back can see. The question is, can you use nicotine replacement therapy for life? And the answer is yes. It's just nicotine. People smoke their whole lives. you can use nicotine for your whole life. The main problem is, can you get your insurance to pay for it, and do you want to pay for it for your whole life? But you can use it as long as you want. In general, the research now is suggesting for people who are quitting smoking that you should encourage them to use it for at least a year. There's good evidence that using it for a year really helps people quit and stay quit. Smoking it's so hard to quit, and it's so hard to stay quit. I know, I used to smoke. So I want to encourage you to think about these as more long-term treatments. These are chronic relapsing conditions, and we need to be thinking long-term. If somebody quits and then they relapse, don't give up on them. Try again. You know, when they're ready, try again. It's the same for all substance use disorders. You know, don't give up. Just hang in there with people and keep trying, and they will keep trying with you if they feel like you're there with them. Other questions from people? Yes?
What's your experience using Chantix for patients that have severe mental illness or, you know, more one you'd be concerned about?
The question is, what's my experience using Chantix for people with severe mental illness? My experience is that it works great if people are willing to be monitored, if they're willing to meet with you regularly, ideally each week, tell you how they're doing. If they start feeling jittery or feeling worse, then you just stop the medicine, right? So, I mean, I treated somebody who had serious bipolar disorder and cocaine dependence. We got him stable with his mental illness. We got him off the cocaine, and we're like, come on, you know, how about smoking? He was a 4-pack a day kind of guy. He was on bupropion. We increased the dose. We got him on NRT. He was able to cut down, and then we put him on Chantix with everything else. He got down to 2 cigarettes a day, and it took us 6 months, and he finally quit. So people with serious mental illness need more support, they need more aggressive pharmacotherapy, and they need behavioral treatment in addition to that.
Follow-up question for me again. There are centers where if somebody has had suicidal ideation, they will not start Chantix. I was wondering what you thought about that.
I think I would really evaluate that person. Where are they at? How stable are they? If somebody's in a place where their mental illness is pretty stable and they're willing to be monitored, I'd be willing to try Chantix if they really wanted to. If they're in a place where they're not stable and they're having suicidal ideation now, I would not use Chantix. I would stick with NRT and bupropion. Other questions from the audience?
I have two regarding Naltrexone. I thought that you said that for alcohol use disorder, you would prefer the pill versus injection, or did I hear that incorrectly?
So the question is about, for treating folks with alcohol use disorder, should we use the pill form or the long-acting injectable form of Naltrexone? And the answer is you can use either. It's really patient preference. I said I would use the pill form because that's usually the way I would start. But if somebody was like, I don't like taking pills, I'm forgetting my pills, then using a long-acting injectable is a good way to go. It's also a good way to go for people with severe alcohol use disorders. That way you know it's on board and people don't have to remember to take it every day, especially if their lives are really chaotic. The reality with long-acting Naltrexone is it's really expensive. Insurances don't want to cover it, so you really have to advocate for it to get people on it. That's the reality.
Just something that may be interesting that in many countries in Europe, Naltrexone is used sometimes on a PRN basis by people who want to moderate their drinking on specific occasions, who haven't necessarily been diagnosed with an alcohol use disorder, though I think they meet our criteria because of binge use, but it is used in that way in some countries.
All right, Shannon, you have one other one?
Yeah, just really quick. We thought we had heard that there was a specific gene that can be tested for to see if Naltrexone would work for a particular patient for alcohol use.
I don't think it's standard practice. That may be the case. Anybody here know more about that?
There is a test that can be done at some places that are to do, but it's not just Naltrexone, it's all psychiatric issues. It's like testing your disease.
It's an emerging field.
And we don't know the answer. In the back.
I just would like to say that every insurance plan in the state of New Hampshire covers Minitrol, the long-acting form of without restrictions. There are some, the health insurance exchange plans may have a prior authorization, but both Medicaid require no prior authorization, the copays are minimal, and the commercial insurance plans all pay for it without any restrictions.
Well, so she's saying that there's no restrictions. That's not what I hear from my colleagues, but it's really good to hear that from you. So I hope you will all try using it, and if you are having trouble, then complain.
Is it possible that that's for opioid use disorder? Because I know that's true for opioid use disorder. I'm not so sure for alcohol.
Right. Now, insurance companies pay for both indications regardless.
Great, that's good news.
Other questions? Let's go in the very back there.
I was wondering in the statistical rates, what your statistics were of them coming off of medicine-assisted treatment and having any relief, because I'm not seeing many people come off of medicine-assisted treatment, and there's such concern with the 20-year-olds that they're going to be on it for life.
Yeah, we have to do this on a case-by-case basis, and it depends upon the quality of the recovery, the context of the recovery that an individual has, the duration of use, the type and dosage of use, whether it was low doses of prescription opioids. I think we're talking about opioid use disorder, or versus IV high-dose fentanyl use in the street for protracted periods of time. So as long as it takes is as long as the person needs to be on it. And I think that the usual recommendation is for at least a year of treatment and before you even have that discussion. The person needs to be really highly motivated, but most people will relapse within 2 to 4 months of going off.
That's what I see.
Yeah.
Right. Just to be clear there, but the concern with opiate use disorder, opiates, there's a part of our brain that tells us to breathe, and opiates turn that off. When you take too many opiates, you stop breathing. That's not the case for alcohol unless you're drinking a gallon. It's not the case for marijuana. It's not the case for tobacco. So that's why opiate use disorder is so deadly, is because of that side effect of opiates. So if there's a young person, I know all everybody's worried about putting them on this drug, they're gonna have to be on it forever. This saves lives. Opiate replacement therapy saves lives. It's just so clear. And opiates are so dangerous. I know so many people whose sons, daughters, nephews are dead. And it's just terrible. So, all right, there was another question in the very back, and the lady in the jean jacket.
Hi, yeah, thank you. I'm wondering if you can talk about baclofen for alcohol use disorder. My understanding is that it's not FDA approved.
That's right. It was on my list on the slide with that long list of possible options that are not FDA approved. The studies look quite good with baclofen, so I would advocate for using that medicine. I can't go into in detail, but it's definitely a good option to consider. Other questions? Yes.
I just had a clarifying question about the group therapy models for opioid use disorders. You had up there ACT, and we use lots of acronyms. So is that acceptance and commitment therapy, or is that a sort of
acceptance and commitment therapy? I'm so sorry. I usually say that, across, and maybe that doesn't mean anything to people either. ACT is kind of a spin-off of CBT that is integrated with mindfulness. And it has an emphasis on developing values and very personalized goals, and then working to honor those. I'm not a psychosocial counselor myself, so there are people here who could give you more sophisticated explanations. But I did, until recently, work in a center where acceptance and commitment therapy was front and center in our treatment, and it was just transformative for many, many people. And the mindfulness component is really, really important part of it.
One more question.
One more. Anybody else? Yes, at the back.
Yeah, so I've been working in care coordination for about 2 years here in New Hampshire, and there's a really large surge of methamphetamine and a rise in cocaine.
Yes.
What are we seeing for pharmacological interventions for stimulant use disorder? And I'm curious if anyone is seeing agonist replacement with modafinil or even non-methylphenidate for folks with cocaine or meth use disorders?
So I'll say what I know, and I suspect you know more than I, but studies that have looked at stimulant replacement replacement therapy with stimulants have not been successful to date. Over the years, going back as far as I can remember, decades, people have had hope about certain interventions, various kinds of antidepressants and other medications, stimulant replacement. To date, we don't have anything that's clearly effective. I do know that there's one combination that either has a webinar coming up, you can probably look at it online from the Science Center in Dartmouth, but it's a combination, I believe, of bupropion and gabapentin. That's, again, looking promising, but very much like other proposed therapies. Correct me if I'm wrong.
Yeah, no, that's all right. That's for your psychosocial treatments. You gotta hit it hard with those
Really
folks.
difficult,
Very,
really
very
difficult
difficult
treatment.
problem, yeah.
So we-
One more.
No, it's not a question, I just want to
Okay.
follow up, because I mean, I have a patient that I work with that has had some success with Copamax.
With what?
Copamax.
Topamax, yeah.
Topamax.
For
Yeah.
cocaine.
In the end, you know, we're all biogenetically very different, and our metabolic pathways are very different. So there may be subsets of patients who respond to some of these interventions where others don't. And getting clinical trials that are big enough to tease out those responders is difficult. So trying different things that you might have heard something about, as long as you're supervising somebody carefully, sometimes is all